Hopefully. Clinical program and our teach policy. We don't have a full program for that, but
Doesn't matter. You can sit any place? Okay.
yeah, and that's like
Are you from Minnesota?
yes, job security.
Are they? Oh my gosh, my cousin from Minnesota.
Catherine.
Nice to meet you.
So me, I was Valentine's and chocolate shop. Wonderful. That's been oh my gosh. And I said, salted caramels. Are my favorite.
Okay.
Yeah, that's pretty good.
Good. Easier for a number to remember.
I think that's the same company.
Should be able to.
They've been in Minnesota for quite a while. And, so what are we going to do? We have an hour before that starts. Any ideas? You got plans? What we're doing right?
It's quite efficient.
Yeah, I've changed one too, and I've read through yours, so.
Probably why you're not.
I'll try to steer away from what you've already done, so. Awesome. Works for me.
Yeah, it's me. Want to be up here? Yeah, let's should I just close it out?
Make the ding go away.
Yeah, thank you for that.
They can start recording and start doing it.
Yes, I agree.
It's not even the way we record it.
You've learned it through the years, I'm sure.
I'm just acclimating.
And will we be mic'd or is it just the mics up here?
If y'all stay at the podium, the podium mics are working.
Great.
Is it time? Let me know.
Now it's time? That was quick. Good afternoon, and thank you for coming today. My name is Ronnie Pace, and I am proud to be part of the MD Anderson Institution. I'm part of it in two ways. I'm a volunteer, and I'm also a survivor. I was diagnosed in April 2013 with breast cancer. Maybe a shock to some of you, but it does happen. I am also the past chair of the My Cancer Connection Steering Committee. I'm a charter founder of the Patient Family Advisory Council. I started a male breast cancer survivor support team. I say these things to you because we're going to hit you up later to become a part of the volunteer services, so this is a public service announcement. This past Sunday, June 3rd, was the National Cancer Survivor Day. MD Anderson is hosting a week of entertainment and educational activities to honor those like myself and you and caregivers. Through a series of educational and informative activities, and I encourage you to take advantage of those. A lot of effort's been put into it, and they're all very well done. We do this to honor those people who are living with cancer, through cancer, and after cancer. As I said, I'm a patient and a survivor. Since this survivorship week, I get a few moments to talk about my survivorship. I was asked several years ago what survivorship meant to me. And I thought about it for a minute, and what it meant to me was the opportunity to wake up to many more tomorrows. And after I thought about that, I said, what am I going to do with those tomorrows? Am I going to squander them? Am I going to do something positive with my life? So I became a volunteer at MD Anderson. I listed some of the things that I told you I've done here. I'm not Superman. These are available to all of you. Probably do a better job than I'm doing. The fact is, I go to the volunteer luncheon each year, and there's patients and survivors, caregivers who are honored each year who have given tens of thousands of hours of volunteer time to the institution. I don't even raise my hand. I just sit back and be quiet. So there's all kinds of levels that you can participate as a survivor and a caregiver in this hospital to help other people. I know when I was going through treatment, my first and second time, that's another shocker for you, I got breast cancer twice. It meant a lot to me for a survivor or caregiver or volunteer to come to me and touch me, take my hand and say, can I do anything for you? So don't underestimate the power of that opportunity. On my website, I have a statement that says, when I think of other people, I have less time to think of myself. I mean that. So let's get on with the real good stuff here. I'd like to officially welcome you and our guests at our outside locations at Bay City, Katy, the Woodlands, and Sugar Land. Today you're attending a presentation of Piknic. Piknic is an acronym for Partners in Knowledge, News, and Cancer. It is a part of the Volunteer Services Department of Merchandising. And we bring this series to you in an effort to enrich our survivorship programming. And it is also generously funded by the Volunteer Endowment Patient Support, known as VIPS. We have a mission at My Cancer Connection. And that's to share hope, support, and understanding to all others challenged by cancer, from people like myself and people like you who have been there. I mean, what better source of information could be for somebody who knows what it's like to hear those words? You have cancer. On your desk, you should have, or maybe when you leave, you'll get one of these cards. So I ask you to please take one, consider calling that phone number, and they'll tell you about the different programs that you'll have an opportunity to participate in. Before we begin, I'd like to also remind you that we are being televised. It'll be available later on the MD Anderson website. So if I could continue on and introduce our speakers today, and I've quit trying to memorize the bios. There's just too much good stuff to leave out, so I'm going to read it to you. I hate doing that, but it's just the best way to share it with you. I'm going to be sure I don't miss anything. I'm going to put my glasses on. Use bigger font next time. Dr. Matthew Gallagher is an assistant professor in the Department of Psychology and Texas Institute for Measurement, Evaluation, and Statistics at the University of Houston. Dr. Gallagher received his PhD in clinical and quantitative psychology in 2011 from the University of Kansas. He completed a postdoctoral fellowship at the Center for Anxiety and Related Disorders at Boston University. Dr. Gallagher was previously a staff psychologist in the Behavioral Science Division of the National Center for PTSD and assistant professor of psychiatry at Boston University School of Medicine. His research interests include evaluating the efficacy of transdiagnostic. So I don't remember this stuff? I can't even read it. Transdiagnostic treatments for PTSD and anxiety disorders, identifying mechanisms of change of empirically supported treatments and understanding how positive thinking, for example, hope, optimism, self-efficacy, promotes well-being and provides resilience to PTSD and other anxiety disorders. His research has been funded by the National Institute of Mental Health, the Society of Multivariate Experimental Psychology, and the Department of Defense. He is also the author of over 90 articles, chapters, and books, and is a licensed clinical psychologist. Our second speaker is Dr. Powers James. She is a licensed clinical psychologist as well. She received the doctorate degree in clinical health psychology and intern and postdoctoral fellowship at the Michael E. DeBakey VA Medical Center in Houston. Dr. Powers James is interested in preventive care and health promotion within cancer populations. She also uses evidence-based treatments such as cognitive behavioral therapy, motivational interviewing, acceptance and commitment therapy to help patients with their cancer diagnoses and allow them to live a healthy, well-balanced life. Her primary research focuses on mind-body interventions and the treatment of psychosocial symptoms. Please join me in giving a warm welcome to Dr. Gallagher and Dr. Powers James. Thank you.
Thank you for that introduction. I'm excited to be here today. I'm Dr. Gallagher. I'm a professor at the University of Houston. I'll be talking about post-traumatic stress disorder and cancer, current status and future directions, and then Dr. Powers James will follow and talk in more detail about some of the issues we face when it comes to treating PTSD in this context. So just as an overview about what I'll be talking about today, first I'm going to go into a little bit about what is post-traumatic stress disorder, talk about how it's changed in recent decades, how we currently define PTSD in terms of the symptoms that we look for, and then some of the common issues that we face in terms of clinical complexities, associated features when it comes to when we do identify PTSD, what are the other things we might be on the lookout for. I'll then talk a little bit about PTSD in the context of cancer, some specific conceptual and kind of practical issues, and how likely it is or how common it is typically that we find PTSD to be prevalent in the context of cancer survivors. And then I'll talk about how we currently treat PTSD and the evidence we have today looking at different forms of psychotherapy, a number of different treatments that now have quite a bit of evidence in support of them. So 2 current gold standard treatments, and I'll talk a little bit about some promising treatments that have been studied recently, including by faculty here at MD Anderson. So first, when it comes to defining PTSD, one of the interesting things about post-traumatic stress disorder is that more so than many other forms of mental illness, the diagnostic criteria for PTSD have changed pretty dramatically in recent years. And so previously PTSD was considered one of the anxiety disorders. It was within that category along with social phobia, things like specific fear of flying, things like that. But because of increasing research showing that PTSD is similar to those disorders in some ways, but also quite distinct, in the most recent kind of iteration of mental illness taxonomy, the Diagnostic and Statistical Manual, it's now been broken out to be part of a distinct class of disorders, the trauma and stressor-related disorders. And one of the things that's particularly unique about PTSD is that unlike most other forms of psychopathology, the symptoms for PTSD must begin or significantly worsen following a discrete event. And so, as the name suggests, it must be post a traumatic event. And that's quite different from most other forms of mental illness, things like depression, anxiety, that they might be exacerbated by stressors, but there's not that clear signal where you have some sort of precipitating events and that leads to the escalation of these symptoms. And so that's one of the things that's different about PTSD is you're always looking for that anchor point of what was that traumatic experience that helped to lead to the development of these symptoms. And historically, PTSD was most commonly examined in the aftermath of more violent incidents, things like combat, sexual assault, physical assault, or accidents, things like car crashes along those lines. But more recently, there has been increasing recognition that illnesses such as cancer that carry a significant kind of life threat and danger, that they might also result in symptoms of PTSD. And so that we need to be on the lookout for symptoms in that context as well. And so just a quick overview of how we currently define PTSD, the symptoms that are involved in a current diagnosis of PTSD. There's 5 major symptom clusters. First, you must have the traumatic exposure. So there must be a traumatic event that precipitates all the following symptoms that we'll talk about. The re-experiencing symptoms, and so with PTSD, that experience, whether it is a car crash, assault, whatever it may be, it's not just distressing in that moment, it's the memories of that event that can continue to cause distress, sadness, anxiety for months and years to come. And so the frequent re-experiencing of those symptoms is something that continues and is one of the many ways that PTSD causes significant distress and impairments. Because those symptoms of re-experiencing are so distressing, it's quite common for people to fall into wanting to use avoidance strategies. So if you're having thoughts about this traumatic experience, that's very unpleasant. You want to try and avoid those kinds of reminders. That makes a lot of sense short term, but unfortunately long term, that tends to kind of reinforce and maintain these symptoms. But those avoidance symptoms are a common kind of components of post-traumatic stress disorder that we commonly see. And then there's a negative alterations in cognition and mood. That's basically just a fancy way of saying that it changes your thoughts and feelings in the aftermath of trauma, that it has an impact about how you view yourself, the world, the emotions you're experiencing day to day. And then the hyperarousal reactivity, that people are more on edge, that they're kind of at a higher level of awareness, alertness, they're on the lookout for threats, whether it's kind of physical danger or whatever it may be. And so I'll go through each of these in a little bit more detail. So PTSD criterion A, this is one of the aspects of PTSD that has changed in recent years. So the current definition of what qualifies as a traumatic exposure is a person must be exposed to death or threatened death, actual or threatened serious injury, or actual or threatened sexual violence in one of the following ways. Most commonly, this is by direct exposure. You are the person that actually experiences this traumatic event, whether it is an assault, car crash, illness, or what have you. It is also possible to develop PTSD, though, from witnessing one of these traumatic events in person. And so it could be that in context of seeing an assault, you could be just out on Bella Boulevard and you see a car crash and just you see the aftermath of that. That could be something that's less common, but it can still lead to the symptoms of PTSD. Also more rare but possible is that you could learn that a relative or close friend was exposed to a trauma. By finding out enough of the details or information about that, it is possible that that could lead to these symptoms of post-traumatic stress disorder. And then finally, a newer kind of way that's been identified that's possible to experience PTSD is indirect exposure to the aversive details of the trauma, usually in the course of professional duties. And so this is a recent addition to account for the fact that people like police officers, first responders, EMS attendants, things like that, they might not actually be physically present when terrible incidents, when stressors, when traumas happen, but when they're repeatedly confronted by the aftermath of those experiences, they see people trying to recover very acutely after that. The amount of that information over time might still lead to these kinds of symptoms. But importantly, this must be something that they actually do, they are exposed to themselves, not just something they're exposed to by media. And so after having that traumatic exposure, what commonly develops in the aftermath are the re-experiencing symptoms. And this is something that they can happen in almost anyone that has traumatic events. Oftentimes they dissipate across time, but in some situations they do persist for many months or years. Most commonly, this comes in the form of unwanted, upsetting memories. So you're going about your day, you're trying to think about other things, and the thought just comes into your mind about this incident that you had, this traumatic experience, the way in which that changed your life, impacted your health, impacted kind of what you were doing in work and relationships, what have you. It can also commonly occur in the context of sleep. And so people having extremely vivid nightmares, things reminding them where they're fully kind of reliving the most traumatic or salient aspect of those experiences while they're sleeping, that this can be particularly distressing and often interferes with people's sleep, which is quite detrimental in many different ways. More rare, but still common, are flashbacks. And so this can be while people are awake, they have kind of full-on dissociative experiences where they're no longer feeling like they're present in the moment, but they're kind of going back and re-experiencing quite fully that experience that they had of the traumatic events in a quite vivid or striking way. And then finally, there could also be the emotional distress or physical reactivity after exposure to traumatic reminders. And so if you're confronted by sights, sounds, smells, people, context, activity, the reminders could be almost anything, but when you are exposed to those reminders, that can lead to a very strong kind of physical reaction or very strong emotional reaction. And so needing to meet criteria for the criterion B is having at least one of these re-experiencing symptoms occurring repeatedly across time. And as I mentioned, those re-experiencing symptoms are quite distressing, understandably, so there's typically an avoidance of the trauma-related stimuli after the trauma in an attempt to not have those re-experiencing symptoms. And so this comes either through trying to avoid trauma-related thoughts or feelings, so those are the thoughts or feelings related to whatever the traumatic incident may have been, or reminders. And so again, this could be activities, people, almost anything that reminds you of that. And that varies dramatically for different people based on the trauma that they had. But people can go through a remarkable amount of effort to try and avoid engaging in any sort of activities or any sorts of situations that might remind them of that trauma. And if that's something where it happened in the context of work, or it happened while it reminds them when they go to see a physician, that can lead to a host of negative consequences if people are unwilling to confront those situations going forward. Then there's the changes in how people think or feel in the aftermath of the trauma, criterion D. Sometimes this comes in the form of selective amnesia. People have difficulty recalling key features of the trauma, and this isn't because they had a concussion or any sort of head injury. It's more because of the emotional impact that they have that difficulty trying to identify exactly what happened in different parts of that traumatic experience. There's also just the more general changes in thinking that commonly follow in the aftermath of trauma. People change how they think about themselves or the world, or they blame themselves or the others for causing the trauma. So they start to think that I can't trust anyone I try and get close to will harm me, the world is always a dangerous place, this trauma happened because I'm a bad person, I deserved it, falling into kind of unfortunate negative thinking traps along those lines that really serve to maintain the negative affect and the distress that's associated with these traumatic experiences. There's also a number of symptoms that could manifest that look quite similar to what we see in depression. So negative affect more generally, feelings of sadness, hopelessness, and so forth, decreased interest in activity, decreased difficulty experiencing positive affect. So people are less engaged in the environment around them. They're less willing to do the kinds of things they previously did that they enjoyed. They have those difficulties engaging with things that they typically found quite entertaining or pleasing. Because of the way in which they're changing how they're viewing themselves in the world, they have a lot more difficulty with these activities. And that leads to kind of more stress down the line as well when you stop having the pleasure and the joy in your life. And all this can lead to the feelings of isolation, whether that's actual isolation or you just have that perception because you're falling into those negative thinking traps. Then finally, the fifth main criteria for PTSD are the hyperarousal reactivity symptoms. Sometimes this is more externalizing, so people kind of lashing out at others with irritability, aggression. This could be verbal, could be physical. Sometimes people fall in the trap of engaging in more risky or destructive behavior because they start thinking that the world is unsafe and that they're going to have an accident no matter what. They might start engaging in risky driving, risky sexual activity, behaviors like that, that they believe the kind of world is hopeless, and so they start falling into this sometimes. Hypervigilance is one of the classic symptoms of PTSD, where you go into a new situation, you're constantly scanning for threats, you're on the lookout for anything that might be a sign of danger, anything that you might need to do to protect yourself. And then heightened startle reaction is another classic symptom, where if there's a loud bang, if a door slams, people have that really kind of exaggerated response where they might jump and they're very kind of touchy and jumpy. If you put your hand on someone's shoulder that they don't expect it, they might have a very exaggerated response because of these hyperarousal symptoms. More generally, there's a difficulty concentrating. So as people just go through their day, staying on task, kind of keeping the focus, that can be very difficult for people because of these symptoms. And then finally, the difficulty sleeping. And this is a symptom that actually is often one of the factors that actually leads people to seek out treatment. When I was working at the Boston VA, oftentimes veterans that had re-experiencing symptoms for decades, going back to the Vietnam War, they might say they learned to kind of cope with many of those symptoms, but it's when it started impacting their sleep on a daily basis, when they're not able to get that rest, to get that kind of recovery, that was something that often led them to kind of actually seek out treatment, because that was what was interfering with them on a more daily basis. And so those are the core criteria. There's just a few other factors that must be met in order to officially meet diagnostic criteria for PTSD. Duration, the symptoms must last for more than 1 month. The symptoms must create distress or functional impairments, so they must have a significant impact on your life in some way. This could be in terms of your professional responsibilities, relationships, friends, family, whatever it may be. And they're not simply due to medication, substance use, or something else. They are due to the trauma and the events that followed following that. There are a few possible diagnostic specifiers. The one that's kind of more relevant in the context of cancer is the possibility for delayed specification. So this is something we sometimes see in the context of PTSD, that when people have these very intense traumatic experiences, sometimes in the acute aftermath, they might be more focused on just taking care of all the practical things they need to do, getting food, safety, shelter. You see this in the aftermath of things like Hurricane Harvey, where you're so focused on taking care of those basic things that it might not be for a couple months before the emotional impact really starts kicking in. And so that is something we sometimes see, that people might have all the symptoms of PTSD, but it might take a couple months to manifest. And so it's not something that if we kind of evaluate someone a week after trauma, if there's no symptoms, that doesn't mean that they're never going to develop any symptoms. It still might come in a more delayed fashion. So that's something we have to be on the lookout for. So one thing that's really important to note when talking about PTSD in the aftermath of trauma is just how generally resilient people are in the aftermath of trauma. And so the unfortunate reality is evidence suggests that most people are going to experience one or more traumatic events in their life, with some recent estimates suggesting that as many as 90% of individuals will experience at least one, with many individuals experiencing multiple traumatic events. Fortunately, most people, despite that, never actually develop PTSD. And so recent estimates suggesting that the lifetime prevalence or lifetime odds of actually developing PTSD are only about 7 or 8%. And so what that tells us is that resilience is by far the most common outcome in the aftermath of trauma. Almost everyone is going to develop, or almost everyone's going to have one or more traumatic events, but a small proportion of those individuals will actually develop full-on PTSD. And so most people are able to bounce back in a remarkably resilient fashion. Another way of thinking about this is looking at trajectories of symptoms across time. And so this is something you can see here. There are some individuals that immediately develop symptoms where they have that chronic course of treatment. And of course, for these individuals, we need to provide the treatments that I'll talk about in just a bit. And there are also the individuals that they might not have symptoms right away, but they might kick up a little bit later, 6 months, a year, 2 years down the line. But what's more common are these other two trajectories of recovery resilience. So many individuals in the immediate aftermath of a trauma, they might be understandably quite distressed, have symptoms of PTSD, depression, anxiety. But even if those symptoms are present in the immediate aftermath, they might naturally recover, they might seek out treatments, but when you follow up with them a year, 2 years later, they're very close to baseline. But what's even more common is this resilience trajectory, where there might be a very slight uptick in symptoms after that experience, but they are remarkably stable in terms of their long-term functioning. And when people are classified into one of these four trajectories across a number of different trauma types, it's pretty consistently found that about 60 to 80% of individuals are classified with this resilience trajectory. So again, most people have traumas at some point in their life, but most people are remarkably resilient in the face of that adversity. Just some other complexities or clinical issues that we commonly face when dealing with PTSD. PTSD can have a very large impact on quality of life, functional impairments, relationships, and even physical health. So in the aftermath of trauma, when people have these symptoms, it can impact almost every aspect of an individual's life. And so it's important to be very sensitive to all the different ways that these symptoms might be interfering with someone's life in the aftermath of those traumatic experiences. Unfortunately, the symptoms of PTSD are sometimes missed or ignored, as they can be less visible than more physical markers of trauma. That if you get in a car accident and you break your arm, it's easy for someone to see that you have a cast on, that you're in a sling. People can notice when you're no longer wearing that cast or have that sling. And so those kinds of things are much easier for other people to identify than if you're having nightmares every night. Other people might not be aware of how it is that you're struggling or what symptoms might be present that might be impacting you, because it is harder to detect. And then because I mentioned avoidance being a hallmark symptom, it's often difficult for individuals with PTSD to either initiate or stay in treatment. So a recent study with colleagues at the Boston VA, we found that as many as 30% of individuals, even if we got them into kind of the best form of treatment that we have, they might not complete a full course of treatment, that they would drop out partway through treatments. And this is most common after that first session, that as many as 10 or 15% of individuals sometimes drop out after that very first session of treatment. And so this is one of the challenges, is just getting people into treatment is hard enough, but getting people to stick sometimes can be more difficult as well. There's also many different ways to have PTSD. And so with all the symptoms I just talked about, it's been calculated that with the different ways you can meet each of those different criteria, there's over 600,000 different ways to have PTSD, which is kind of crazy, but that makes it quite difficult for clinicians to identify when people are presenting with PTSD. Because one person might meet diagnostic criteria and have no symptoms in common with other people that might meet all the criteria as well. And so that makes it challenging for providers to quickly identify, be aware of that, because there are so many different ways people might show up with PTSD. And it's also the fact that comorbidity with other emotional disorders is very high. So when people have PTSD, it's very rare that they only have PTSD. It's more common that they at least have one or more additional emotional disorders. In a recent study, we found that the average number of other disorders that people met at some point in their life, if they had PTSD, was 2.8. So nearly 3 other diagnoses being present at some point if you have PTSD. And the lifetime odds of meeting criteria for either anxiety or a mood disorder for both of those was 90% or greater. And so when people are having symptoms of PTSD, there's other things that are typically going on as well that we need to be sensitive to when planning our treatments. Another thing that's important to note is that PTSD is not the only possible outcome after trauma. Many individuals actually report positive changes in the aftermath of traumatic experiences. This is commonly called benefit finding or post-traumatic growth. And this can take a number of different forms. Oftentimes people report that they have a greater appreciation of life, relationships feel strengthened, they're more aware of their personal strength, they feel more confident in themselves in the aftermath of these experiences. It's important to note, PTG is not universal, and it's not required to recover from PTSD, but it is quite common. In a recent study looking at colorectal cancer survivors 5 years post-diagnosis, nearly half of those individuals reported high levels of post-traumatic growth 5 years after having that experience. So again, it's not universal, but it's quite common. It's actually more common than PTSD in the aftermath of traumatic experiences. So talking more specifically about PTSD in the context of cancer, as I mentioned, historically PTSD was more focused on violent accidents or injuries, but it has been increasingly recognized that things like cancer could also result in symptoms of PTSD. The key challenge when it comes to conceptualizing cancer as a traumatic event is that the stress and threat of cancer is not isolated like a car accident. It's not something where it happens in 2 or 3 minutes, where you're injured in a couple minutes and then it's taken care of. A cancer diagnosis, a treatment, it could be months, years. It's much more of an ongoing stressor. And so that's led some people to question, is this best conceptualized as PTSD or is this a different kind of stress disorder? And so this is something in the current kind of diagnostic manual, the way that this is currently described is a life-threatening illness or debilitating medical condition is not necessarily considered a traumatic event. Medical incidents that qualify as traumatic events involve sudden catastrophic events. And so a diagnosis of cancer is not automatically something that meets criteria for PTSD, but it very well can be given the certain circumstances and the criteria or the aspects that are involved. So it is possible to consider it a criterion a traumatic event in the way that we currently have our diagnostic system. In terms of the prevalence of PTSD, when people are asked about the characteristics of the cancer diagnosis and treatment, one recent study in lung cancer survivors that the majority, about 57%, reported that the diagnosis and treatment of cancer did meet criteria for it being a traumatic event as we currently define that. And the estimates of PTSD prevalence vary quite a bit based on different kind of methodologies that have been used. But a recent review of the literature found that when using kind of the best practice methods of clinical interviewing and looking across different cancer types, about 6.4% of cancer survivors meet current PTSD diagnostic criteria, with lifetime estimates about twice that of 12.6. And so a little bit higher than what we might see in the general population, but again, by no means is it the most likely outcome in the aftermath of a cancer diagnosis that people are guaranteed or more likely than not to get PTSD. So when it comes to treating PTSD, the American Psychological Association's clinical practice guidelines for PTSD strongly recommend psychotherapy as the first and best treatment option for PTSD. Specifically, different variations of cognitive behavioral therapy are currently the best treatment option for PTSD. So we'll talk a little bit about two gold standard CBT treatments, the ones that are most widely used in, say, the VA system. They're being disseminated nationwide in their PTSD clinics and have the most kind of clinical trials supporting their use. But also two newer but promising treatments for PTSD, transdiagnostic treatments and expressive writing. I just want to note that medications, things like sertraline, paroxetine, they are also sometimes used in the treatment of PTSD, but there's less evidence of efficacy for medications than there is for psychotherapy. So that's what we currently recommend when people meet full criteria. So just want to say a little bit about each of the four treatments now. Cognitive processing therapy is treatment that's primarily focused on cognitions or the thoughts that are related to traumatic experiences. And this grew out of Patty Reesick's work at University of Missouri St. Louis with female rape survivors suffering from symptoms of PTSD. And so in CPT, the treatment focuses on identifying and challenging stuck points or the problematic thoughts related to the trauma that maintain PTSD symptoms. So helping patients to identify beliefs like, I can never trust anyone I get in a relationship is going to attack me, the world is an unsafe place, I'm doomed to have these kinds of traumatic experiences, identifying and then kind of breaking down and challenging those cognitions. Treatment is typically delivered in 11 or 12 weekly or biweekly 50-minute or 90-minute group sessions. And there's now multiple large clinical trials demonstrating the efficacy of this treatment approach, showing that across many different types of trauma, this is quite effective at reducing symptoms of PTSD. And so this is one of the two kind of gold standard treatments that we currently have for PTSD. There's also prolonged exposure therapy. This is developed by Edna Foa and colleagues at the University of Pennsylvania. And so in contrast to CBT, which focuses more on cognitions, in P, it's focusing more on the re-experiencing symptoms. You develop a fear hierarchy with the help of the therapist to think about what are sequential steps of things that I can confront with the support of the therapist and in between sessions to kind of challenge those fear memories that you might have. So if you have a car accident, you might start by, what if you just pick up your keys again? What if you go stand by your car? What if you get in the passenger seat? What if you get in the driver's seat? Turn on the car, drive around the block. Sequentially go through these kinds of steps that remind you of that traumatic experience to confront those feared memories, to get past the limitations that you have in the aftermath of that traumatic experience. Similar to CPT, this is typically delivered in 9 to 12 weekly or biweekly sessions, and there's also lots of evidence in the support of PE being an efficacious treatment for many different types of trauma in the aftermath. So this is the other kind of best practice treatment that we currently have in the context of PTSD. The Unified Protocol is a newer form of cognitive behavioral therapy that colleagues and I up in Boston have been looking at for a number of years now, where the focus here is that rather than focusing on disorder-specific features, because we know in PTSD and other disorders, it's not just that you only have PTSD, but you might have depression, anxiety, multiple other things present. The idea with the Unified Protocol is if we target those features that are common across those different emotional disorders, that might cascade out to take care of all the different disorders at once, rather than focusing on disorder-specific features, where you then might need to have your treatment for PTSD, and then you have a treatment for depression, and then you have your treatment for anxiety, which that's just not practical for patients, providers, anyone to have to go through so many different treatments like that. And so it focuses on cultivating emotion regulation skills, things like mindfulness, cognitive reappraisal, that should be relevant across different diagnoses. And it's designed in a flexible manner. So based off of individual deficits or strengths, you can identify what are you particularly struggling with and deliver it using a modular approach with 12 to 18 sessions based on the needs of a particular client. And we recently published a study showing that, for at least for anxiety disorders, the Unified Protocol is just as effective as existing kind of gold standard CBT treatments. And we also have some promising effects when looking at this as a treatment of PTSD. And currently studying this in collaboration with colleagues in Australia, looking at this as a treatment for PTSD and the aftermath of health injuries and other incidents. And then the final treatment approach I'll talk about today is expressive writing. And so the idea here is to look at very brief writing interventions as a potentially more efficient alternative to these more intensive treatments that I've already spoken about today. And so the approaches vary, but often it's just 3 to 5 sessions where you spend 15 to 30 minutes writing about the traumatic experiences, where you might get a little bit of psychoeducation about PTSD, about trauma, how it might impact individuals, and then you have someone just sit down by themselves and write about their traumatic experiences, which doesn't sound like it might be enough, but actually seems so far to have a remarkable impact on people's symptoms. And there's promising evidence that written exposure therapy might be just as effective as longer forms of CBT across many different traumas in a study that came out quite recently. There's also some promising evidence specifically in the context of PTSD and quality of life in cancer survivors. So looking at the evidence of using expressive writing, different forms of that in the treatment of PTSD, promoting quality of life, with Chen Liu, a colleague who was at University of Houston, is now MD Anderson, doing some really interesting work in this area. But interestingly, the work that we did looking at these symptoms in Chinese American breast cancer survivors, we found that although it was quite efficacious typically when looked at in Caucasian samples, when looking in these Chinese American samples, the effects were a little bit more mixed. And so again, speaking to the importance of needing to be culturally sensitive and recognizing that treatments that might be effective for one group might not be universally effective. So just some takeaways. This is not news, but it's worth pointing out again that cancer not only has profound effects on physical functioning, but also on emotional well-being. And this is true not only for patients, but also for family members and caregivers. It can be an extremely stressful process that is not just an isolated incident that you take care of in 1 week, but can continue for months or years. And so it can have quite a toll on people's functioning. But fortunately, people are remarkably resilient. And so PTSD and other emotional disorders are no means guaranteed following cancer or other traumatic experiences, but they do commonly occur at enough of a rate that we do need to be sensitive to and aware of identifying these symptoms so we can get people the treatment that they need. And the good news is effective treatments for PTSD exist, and the majority of patients report clinically significant recovery following a full course of CBT. So if we can get people in the door to start these treatments, we can have a pretty profound effect on their functioning in the aftermath of these traumatic experiences. And so if you think you or a loved one might have PTSD, ask for help. PTSD and the symptoms are by no means a sign of weakness or something to be afraid of. It's something that can happen quite commonly in the aftermath of trauma, but we do have good treatments for them. We just need to get people in the door so we can help them recover in the most efficient and effective way possible. And just some resources that are worth kind of pointing out. The National Center for PTSD has a lot of great resources for both patients and providers at ptsd.va.gov. There's a lot of resources here at MD Anderson, psychotherapy. Dr. Powers James can talk about this in more detail, CBT, cancer support groups, social work, and what have you. And the Trauma and Anxiety Clinic of Houston, that's a clinic that I run over at the University of Houston with colleagues, where we specialize in individual and group CBT for PTSD and anxiety disorders. And not a huge clinic, but we try and provide these services on a sliding scale basis to help kind of provide access to these evidence-based treatments. And so with that, I will turn it over to Dr. Powers James.
Okay, so Dr. Gallagher gave us an excellent idea of what PTSD is and laid a lot of the foundation for what I'm going to talk about next. So what I'm going to talk about, again, go over some of the specific things on cancer and how it might lead to PTSD. I'm also going to touch base, because I'm sure there's a lot of probably caregivers in this room, how family members can also get PTSD, which Dr. Gallagher mentioned about how people witnessing or being along for the journey could also develop PTSD. Another topic that I think is also important, somewhat related, is how PTSD might have some associations with later developing cancer. I'm going to talk a little bit about post-traumatic growth also, and then do some case studies about some of the patients I've seen here at MD Anderson. So as Dr. Gallagher said, a lot of our patients here at MD Anderson, anyone who's been diagnosed with cancer, it is very often that they see or experience cancer as a traumatic experience. And as he talked about our manual that we use to diagnose PTSD, it's changed recently. So prior, it was more simply a threat to life or physical integrity, and a response was with fear, helplessness, or horror. However, now it's gotten a little bit more stringent in what classifies as PTSD, which I think has been very helpful at trying to make sure that we truly are diagnosing those people that have PTSD with PSD and not missing anyone, and at the same time not just labeling people who have with PTSD who don't have PTSD. So the new one, as he mentioned, is a life-threatening illness or debilitating medical condition is not necessarily considered a traumatic event. So just because you have cancer, That does not constitute a traumatic event. And we'll talk about that a little bit more later on. And medical incidents that qualify as traumatic events involve sudden, catastrophic events. So towards the end, I'll give an example of that. So cancer is a little bit different than some of the traditional stressors. So over the years, as Dr. Gallagher talked about, we've looked at abuse, we've looked at combat, we've looked at all these different types of stressors, car accidents. But cancer is a little bit different. For probably the vast majority of our patients, it's not that suddenly you're in the hospital and your life is threatened that exact day. It's live or die that day. Instead, you either find a pain or a symptom or something that leads you to go to the doctor, or perhaps you're just getting your annual mammogram or something else like that, and then you go to the doctor for a checkup and get information on the scans, and then you learn you have cancer. So it's more, for most cancers, informational at first. And of course, if you, for example, if you told your dog you have cancer, what is the dog going to do? It's just going to look at you and wag their tail. Their life is not immediately threatened. However, for a human, we understand what that means. We know what the term cancer means, and we have all these other thoughts that are surrounding it. For most people, they remember when they first heard you have cancer. And for most people, it isn't a pleasant experience when they hear those words, and they have a flood of thoughts, and usually they're very negative. In addition to that, cancer is very different than combat or a car accident, because you're probably going to have to deal with it for the rest of your life. It's not something that has a final date. It keeps going even when you're done with treatment. For most cancers, you have a follow-up visit indefinitely. You have a treatment that is going to prolong health issues. It's going to have side effects you'll have to battle. For many of us in this room, once you get cancer and go through treatment, other cancers could also happen to you. You're at higher risk for so many other things. So unfortunately with cancer, it's not an isolated one traumatic event that has a beginning and an end. It keeps on going. And that certainly makes things more complicated when we're talking about a traumatic stressor. A few other things that can complicate things is the treatment and the cancer itself can make some of, Dr. Gallagher went through all these different criteria that we need to diagnose PTSD. For example, some of your treatment, it might cause you to be more forgetful. It might cause you to not remember things. I'm a cancer survivor myself, and I remember going and taking well, I don't remember too much. I know that I went and I took my mom to a doctor's visit. But I remember nothing of going there and being there because of the treatment. I was in a fog the whole time and can't recall it. I also remember another time a friend calling me and asked me, did you have chemo today? And I was so out of it, I didn't even know if I had chemo that day. So the brain can certainly trick you in many different ways, whether it's treatment related or if it's leading to PTSD. So it certainly complicates the diagnosis. Also, he talked about how a common response is to blame ourselves or others. With cancer, it can be tricky. A lot of people, for example, who have lung cancer that have a history of smoking, they might blame themselves, and they might actually have some responsibility in it, that it's not that they're blaming themselves in a different way than traditional PTSD with combat or sexual assault. So it makes things very, very complicated. Also, you might not want to do things that you previously enjoyed doing, and you have a good reason. If you are in excruciating pain and you used to be a marathon runner, yeah, you might not want to go run a marathon anymore. So there might be really real reasons for you no longer being interested in things that you once enjoyed. So part of our job, which makes cancers very difficult, is teasing apart what is PTSD and what do we expect with a typical cancer survivor. And looking at a timeline and all this information makes it complicated, but it's very important for us to invest in that time to do so. Lots of different risk factors. Doesn't mean you have to have any of these. Anyone can get PTSD from a cancer diagnosis. However, these are some that we find to be more common. Young age, advanced disease, recently completing treatment. With most of the patients I work with, it's really not, the anxiety doesn't increase during treatment as much as it does even after completing treatment, because you're no longer on that survival mode, and that's when reality sets in and you can start to think about what you just went through. Low socioeconomic status, you might not have as many resources or support system, lower education, again, other psychiatric conditions, limited support system, or even a negative support system, invasive treatments, or dissociative symptoms regarding the cancer experience. So what we do know that PTSD in the general public, so not cancer related, it may lead to worsened health behaviors in general. So people who have PTSD, they might not take care of themselves the way they might be isolating at home. So they're not going out, they're not socializing, they're not exercising, they're not eating nutritiously. We don't have conclusive data yet with cancer-related PTSD, but our hunches and what we're looking at is it's probably going to be very similar to the general public, that if you do have cancer-related PTSD, that you might be more vulnerable to health issues. So as, again, Dr. Gallagher talked about, there's some really, really great treatments out there that work with cancer-related PTSD. The first two that he went over in great detail, the cognitive processing therapy, one of the types of treatments I do with most of my patients who present with PTSD, exposure therapy, stress management techniques, coping skills, mindfulness, narrative therapy, and also pharmacological. In addition to the pharmacological not having as much evidence as psychotherapy, another thing to note is cancer survivors tend to also have a lot more complex health backgrounds. So we need to make sure that you're going, if you are seeking pharmacological treatment, you're going to someone who's aware of the potential health issues that might go into selecting the best medication. Luckily at MD Anderson, we have psychiatry here, so you can talk to them and they can best prescribe medication if that's the route you decide to go. Another thing that is, again, really important to mention, you don't have to be necessarily a cancer survivor yourself. What we find is mothers, spouses, siblings, all those people, I mean, you're spending countless times with the patient. A lot of people talk about the helplessness they feel watching their loved ones suffer and feeling that they can't do much about it. They can't take away their pain. And seeing, sometimes you see even more and you remember more than even the patient themselves. So you're also at risk to develop PTSD based on the new criteria. Another thing to also, I think, discuss briefly is, can PTSD lead to cancer? And we're not sure, but the evidence looks like this might be a possibility. So what we know is the traumatic event is a significant stressor, and it's a prolonged chronic stressor. And when we're under chronic stress, we have, and I don't know if anyone's heard of the fight or flight response, but your fight or flight response is activated, and it can affect your immune system greatly. So this might make you more vulnerable to develop cancer. So this is still a theory, we're still looking into it, but there's certainly a lot of evidence that is suggesting that. So it's that fight or flight response, or what the official term would be the sympathetic nervous system. And when that's activated and stays activated, that's what can lead to some problems. So I'm not going to go over all of this because it's pretty detailed, and you probably have to have a biology degree to figure out half of this. However, what it is it can certainly change your genetics when you have prolonged exposure to a trauma. So say it's something completely prior to cancer. Say you had a really rough childhood. Say you are a veteran and you experienced combat. Say you were involved in a major accident in the past. Whatever it might be, if you develop PTSD from that event, you might be more likely later down the road to develop cancer. This is a relatively new area that we're looking in, so we don't have so many details on specifically what cancer is, but we do know this can affect your immune system, your genes, your mutations. There's a lot of things that can be triggered. And one way that we started looking at this, and this is something that we use at MD Anderson, is a questionnaire called the ACE, and this is specific for child adverse experiences. And it's probably really difficult to read up there. I apologize for that. But it has questions such as, did a parent or other adult in the household often insult you or put you down or humiliate you? Did a person in the household throw things at you or abuse you or injure you? Talking about, have you ever pushed or grabbed or slapped or any physical abuse? And what we do is we look at these to look at the childhood and how stressful your childhood is. And what we have is evidence that has linked this. The more time or the more items on this that you endorse, the higher your risk is for developing various health issues, including cancer. So as you can see here, when you have the higher rates or scores on this questionnaire, it is linked to lack of physical activity, smoking, alcoholism, drug use, and missed work. But in addition to that, it's also linked to diabetes, heart disease, cancer, stroke, COPD. So this is an area that we're certainly looking at because it's important to figure out in the general population, if you're experiencing traumas, if you're experiencing a traumatic childhood or whatnot, that we really need to be able to treat these people quicker. We need to start to reduce the chronic stress. We need to get them in to see Dr. Gallagher and address these issues so it doesn't later turn into health issues. So a few things with post-traumatic growth. For post-traumatic growth, specifically with cancer survivors, what we notice is common outcomes for people who have PTG are improved relations with others, new life experiences, a greater appreciation for life, a sense of personal strength, and spiritual development. And I'll go over a couple of case studies of this later on. So ways to encourage growth. First of all, reduce anxiety. First of all, we have to figure out when you're feeling anxious, and then we need to work on reducing anxiety. Reflect on your experience, restore a sense of safety, connect with others, and create a post-trauma life vision. So with that, I'm going to talk about a couple of experiences I've had. The first one I'm going to talk about is specifically PTSD cancer related patient. He was a gentleman in his 40s that I saw, and he was living a normal life, had children, married, successful at his career, and he had some aches and pains here and there, but he was one of those tough Texan guys that, didn't want to go see a doctor. And then all of a sudden, one day, he collapses. And the next thing he knows, he wakes up in the ICU. He has cancer. He can't talk. He can't move. And he's that way. And he's hearing providers talk about how his prognosis is poor and he likely won't survive the night. And he actually does survive the night, but for the next month, he can't move or speak. So this is, I think, a classic traumatic experience. His life is threatened. He even hears the doctor saying that it's unlikely he's going to survive. I think anyone can imagine how difficult that experience would be. And he certainly met criteria for PTSD. He's someone that he had unwanted memories, nightmares. He had flashbacks, which actually we don't see too often, but he suddenly would imagine himself or feel as if he was back in the ICU. And certainly emotional distress. He avoided reminders of his cancer when possible. Luckily, and this is one of the problems too, he continued to go to follow-up visits. I know a lot of our patients, when they do have avoidance, they want to avoid MD Anderson at all costs, which makes it difficult too. But I think his wife certainly pushed him in the right direction to continue to come here, seek treatment follow-ups. I know that many of you who are survivors here can relate to scanxiety. When you have a follow-up appointment coming up, a scan, anxiety certainly shoots up. So a lot of us want to push those visits off, kind of ignorance is bliss. But with that, luckily he was going, but he avoided anything that could remind him of cancer. Significant memory gaps. This could be also complicated based on the cancer, but it seemed like it went beyond just what you would expect given his prognosis and diagnosis. He felt isolated, which a lot of our patients do. Most people I talk to, they don't feel that everyone knows what they're going through. They feel very alone. They feel that people can't understand. And then sometimes it actually feels really good when you meet another cancer patient, whether you're in the waiting room or somewhere, a support group, and you don't feel so alone. But it's very common for our patients to feel this isolation. Feeling as if no one understands and difficulty feeling joy. He also had sleep disturbances, a lot of nightmares, and difficulty with concentration. He felt like his brain, which I think a lot of our patients say, just isn't working the same and can't concentrate, difficulty reading, all those things that probably many of you in here can relate to. A couple of other people, unfortunately, I have seen multiple people that come to me who have a history of PTSD and then later developed cancer. So I've seen people, of course, with some of the common ones: child sexual abuse, rape, physical abuse, car accidents. A lot of patients come to me, they have not worked through that PTSD. And part of their goal is, hey, you know, I know this could affect my health, so it's time for me to make a change. Another thing is that these people can also seek Dr. Gallagher, go out to the community too. Highly recommend it if you have a prior experience with PTSD, or if you know someone who has PTSD that's not in this room, even if they don't have cancer, please, please, please encourage them to seek treatment. So post-traumatic growth, I have a father that was the patient and a daughter that hadn't spoken to each other in decades. But yet, because of his diagnosis, that they actually connected again. And before he passed away, he said, even though he has cancer and he knows he was going to die from it, it was the greatest gift he could have gotten because he was able to reconnect with his daughter. Another one, I have another patient who talks about this new normal. That she's better for what she went through. At first, she really struggled because she saw all these people talking about drama and worrying about the little things. And she would get very frustrated. But with time, she developed this new normal, and now she takes better care of herself. She started working out. She took a job. She hadn't worked in decades, so now she has more meaning in her life because of that specific job she took. She has more appreciation for little things like her son. She stays away from the drama in her life. And she and her husband decided that they've been talking about buying a boat for years and years and years and years. And they finally, after her cancer diagnosis and recovery, she finally went out and bought that boat, and they have gone sailing several times on it, living the dream that she's always had. Luckily, a lot of people, when they find out what I do, you work at MD Anderson in psychology. Oh, how sad, how depressing. How do you do that? And I tell people I love it. And one of the reasons I love it is because I get to see people go through this journey that can be incredibly scary. I can see the pain, the hurt, but I also get the honor of seeing the other side, people growing from this experience, learning from this experience, being able to make a difference and find more meaning in their life. And I luckily get to be along for that ride. So just to kind of summarize again, PTSD, it could be prior to cancer, it could be post-cancer. Either way, I think it's crucial to seek help. You are not alone. Unfortunately, PTSD is pretty common for both cancer-related and non-cancer-related, and it's really important for us to make sure that you guys are getting the help that you need. It's very complex. I'm sure in another 5 years we can come back and talk to you about other changes that they've made, and it might be a completely different talk. And also, just because you don't meet criteria for PTSD, if that's the case, that doesn't mean that you shouldn't still get help. There might be another thing that you meet criteria for, but either way, if you are suffering, if you are not living the life that you want to live, we are here. We can help, whether in the community or here at MD Anderson. So just know that help is out there. All right. I think that questions after that?
Thank you guys. This is great for me. I hope y'all enjoyed it as well. We have a microphone at your desk, and the other groups outline areas. So raise your hand or holler or something, I'll call you. So let's open the floor for questions. Yes, ma'am.
Dr. Gallagher mentioned about the cognitive reappraisal, and Dr. Powell James mentioned about cognitive process therapy. Are those concepts the same? And then you can elaborate a little more about the cognitive reappraisal, and then is this something that you can do by yourself, or you need a professional specialist to guide you?
I haven't heard of anyone doing it themselves. It'd probably be quite challenging. Cognitive processing therapy, I always tell my patients that it's hard. It's really hard. It is not an easy thing to sign up for. Probably part of the reason why a lot of people drop out, especially in the beginning, because it sometimes gets worse. It sometimes gets worse before it gets better. Typically what it involves is, and there's revised versions as well, but it will start to have you re-experience through writing what you went through. And then there are certain themes that we'll go over that are common for patients to experience, like trust issues. Trust issues is a common thing that a lot of people with PTSD tend to experience. So we go over different themes with very specific topics to help you navigate through that. So typically it is done in about 12 weeks. It's a manualized, I use a little bit of flexibility, but a manualized program that's every session is already written out, and we have a protocol that we follow. It was developed in the VA. Both of us have experience with the VA. I'm sure no surprise here, the VA is certainly on top of the treatment of PTSD, and they've done a wonderful job. Again, it's a very difficult treatment for patients to go through because it does do exactly what you're trying to do. You're trying to avoid thinking about cancer and what you're going through, and it makes you not avoid it and to actually go there and process it and give yourself the opportunity to see it in a different way and use these themes to start to move forward in your life. And I don't know if you want to add some more too.
Yeah, there are some self-help books that are kind of written by people who also are doing this kind of research that are more consistent with these treatment approaches, but there's not as much data saying that people just using those by themselves, that will be as effective as going through therapy. And so we typically recommend that kind of seek out the help of a therapist so you have someone that can help you walk through. So you're identifying these cognitions, whether it's overestimating the probability of negative events or catastrophizing, kind of identifying those common kind of thinking errors, and then using these skills to kind of slowly challenge, break down those thoughts, do some of the writing exercises Dr. Powers-James spoke about, and then across weeks that can be very effective in reducing those cognitions.
And in addition to that, with the writing, you actually bring in your writing and you read it out loud to the therapist, which there's two things. First of all, you have to speak the words, which is getting to a different part of your brain to actually say it out loud as opposed to just writing it. In addition to that, the therapist can make sure to guide you that you're getting in touch with your true emotions. So if I sat up here and if I had a traumatic experience and I was reading it like a robot, it probably isn't going to do much for me. But if you have a therapist with you, they can help guide you and make sure that you're getting in touch with those emotions and having some of those going back to that trauma.
That's a great question.
The buttons in front of the microphone.
Yeah.
Not on top. I got it.
With the alternative techniques and high technology that uses neurofeedback or...
Yes. So we have, I have biofeedback equipment here that's collecting dust as we were working through insurance issues. But biofeedback actually is a really neat treatment modality as well. It works well with the anxiety and the stress. I don't know how much evidence is in there for PTSD specifically.
There's less for PTSD. It's kind of a useful coping tool or kind of strategy for anxiety and stress, as she mentioned. But I think there's less evidence that by itself would kind of take care of everything with PTSD.
And for those of you who are not aware, because I know biofeedback is not in most people's common day language, it is where we more or less we hook you up to a machine and it provides us with feedback about how your body is reacting. So it can give us information on how you're breathing, your heart rate, how much you're sweating, your body temperature, all these things that can help us look at the way your body is responding to certain stimuli. And then what we do is we also teach you relaxation techniques. And you can see right on the monitor, oh, when I do this relaxation technique, my body responds. I think it's really neat. And hopefully we have the equipment here. We're just hoping to get that started hopefully sooner than later.
And with the artificial intelligence, have they developed a function which they have stimulated with electricity?
And I'm not as familiar with artificial.
I think that's a really interesting area of future research, but I don't think there's a great deal of evidence so far with how that might be used in treatment right now.
Could you, I know you talked about doing CPT on your own, that it's not recommended, but could you differentiate the CPT and the CBT?
So CPT is a type of cognitive behavioral therapy. So cognitive behavioral therapy is the umbrella term, and then cognitive processing therapy falls underneath it.
Okay.
Does that make sense?
Yes.
And there are plenty, again, there are plenty of self-help books. There are strategies you can learn. They can be very, very helpful. The research still says what's the gold standard would be to work with a therapist doing something like CPT. But certainly anyone individually can go out there and, I mean, there's so many materials online. There's self-help books. There's endless amounts. CBT's been around for decades, very well researched with probably the vast majority of mental disorders out there. We have CBT techniques for them. I don't know if there's any other.
Yeah, the acronyms do get confusing, but CBT is like the umbrella term, as she said. So if anything, whether it's cognitive processing therapy, prolonged exposure, unified protocol, those are all different forms of CBT.
Hi, I have a question. I know that you talked about PTSD not necessarily happening after cancer, but a lot of people do report distress and stuff. Are there any types of differential diagnoses that maybe you see that's not necessarily PTSD if someone maybe relates to some of those symptoms, but it's not necessarily? Do you see other things like that?
Oh, for sure. I mean, the vast majority of my patients do not meet criteria for PTSD. But I mean, we have probably the most common one that I see is an adjustment disorder. So and I talk a lot of times to patients about how they're responding in a normal way to an abnormal situation. So it's not surprising that if you get cancer, you have nightmares. It's not surprising that you have all these things. Of course, we do want to address it and treat it. So we have, I mean, you could have depression. There's certainly several different depressive disorders that you might develop. It's just endless with different things that you could qualify for, even if you don't meet criteria. And it certainly should be treated. And again, the vast majority of patients aren't coming to see me for PTSD.
And the CBT treatments we have are also very effective for those other forms of anxiety, depression, whatever other symptoms might be manifest in the aftermath. We do have treatments for that as well, and those can definitely be effectively treated.
That's right.
Well, do y'all find that chemo brain, what they qualify as chemo brain, is that also part of the PTSD, or is it totally independent and it stands on its own in a way?
So my theory of chemo brain, which until recently I don't think the doctors really acknowledged as much. They just thought it was in our heads. But it is, I think, chemo brain we use as a term, but I think it's much more complicated than chemo causes this. I think there's a lot of different factors that play into chemo brain. I mean, I have patients who have radiation brain or surgery brain, and I think it's a combination of different medications you might be taking. Chemo, it might be the stress. It might be a lot of times when your life is at stake, you're probably going to not remember where you left your keys because it's on the bottom of your priority list. If you're feeling anxious, you have your blinders on and you're not going to think about the other things. So I think there's a lot that contribute to chemo brain, and it's very complex and not so simple.
I have another question based on that. Now, y'all are talking about, and I know y'all do because I'm there, y'all have a psychiatry department, and I'm a patient there.
But when you need the therapy, so in other words, they've done what they can to bring you to a certain level. So in other words, you're under the medication to get rid of the anxiety, the depression. So you're taking these medications, but now they're like, we've gotten you to this stage. Now you're into the psychotherapy kind of thing. Is it done here or is it done at U of H?
Yes.
Yes. Okay.
So it can be done either. So first of all, the way I view pharmacological interventions is a lot of times what it does is it helps you to be able to do the work in therapy. So some people talk about how it takes the edge off. I don't think they're two separate phases. I think they can certainly overlap. I think it's never too soon to start therapy, I mean, with some exceptions. And you have it available. We do have psychologists and counselors here at MD Anderson. We also are lucky enough to have Dr. Gallagher in his clinic at U of H, which work on a sliding scale. So here at MD Anderson, we do accept most insurance, and the counselors, I believe, there's some in supportive care if you qualify for that. But we have 2 psychologists in integrative medicine. I'm one of the 2. We have a psychologist in pain. We have 3 in supportive care. We used to have 1. We actually had 2 in body image. They're recruiting for those because they've moved on to bigger, better things. So we're kind of scattered throughout the hospital. In addition to that, we do have amazing community resources with psychologists and other therapists that are familiar with cancer. So you can certainly utilize that, especially for people that sliding scale works better for them. That certainly is a wonderful option. I don't know if you want to talk more about the community too.
Yeah, I think the key is like if you're getting the evidence-based treatments, if you're getting a form of cognitive behavioral therapy, if that can be done here and you kind of, that's easier because you have other appointments, great. You're going to get good care here. If it kind of logistically, it's easier to do that in the community, kind of sliding scale. Just, I think you want to find a provider that does what's kind of currently empirically supported, and then wherever you can do that, make that happen, whether it's community here, other kind of facilities. If you're a veteran, the VA has a lot of great resources, things like that. But.
And also, I know many of our patients are not from Houston, so they certainly can go back. I like Psychology Today is a website that you can look at therapists and see their profiles, and you can talk to them. You can see what type of therapies they do. So that's one of the larger ways to contact therapists in your local area if you're not from the Houston area and you're going back home somewhere else.
Let me ask one more time. Any of the outlying campuses like to ask a question? It's your last chance. Okay. Okay, we got a few more minutes here. If y'all got quick questions, we got about 2 more minutes. Dr. Gallagher, Dr. Powers. Thank you.
Thank you.
Thank you.
Well, like I said earlier, one of my survivorship comments was to wake up to many more tomorrows. Today's a good example of that. I'm glad I was here today to hear this. On your desk should be a form to fill out about today's presentation. We use these for evaluating to make these programs better. So please take time to fill that out. If you think something later on, you can email the institution at the mycancerconnection@mdanderson.org. So thank you all for coming, and thank you, Dr. Gallagher, Dr. Powers.